Thank you, Johan, for having me, absolutely. How many of you were at the plenary lecture yesterday that I gave? Okay, some of this will be a little repeat, but we will manage. So okay, this guy here. That way, okay. Disclosure is not really relevant to this lecture as such. So I will give a short introduction, tell you what International Society for Arthroplasty Registries is, and the Nordic as well, and then how we classify register data, where level 1 is what you should start up with when you start a registry, and down to 4, which is radiographic interpretation. I will give you examples of these different levels from different registries, level 2 to 4 data. How can that be used? I will take what Hierarchical has done in Sweden, the PROM database, and how that can be used, and I will end up with an award paper that we got out of the Harris Joint Registry from Massachusetts General Hospital. And finally, some remarks of the registry in US that now seems to be starting. Arthroplasty in US, this is the predicted cost and development of hip and knee replacement. Reoperation cost this year is estimated to be $1.5 billion. And I wonder if they can afford not to set up a registry. We know we need to do this on scientific evidence. The problem is to collect scientific evidence in total joint surgery. It's cumbersome to do this in randomized clinical trials. We can't do level 1, which is the optimal way to do it. And the way to do this is observational studies. In order to get the base level, Registry Level 1 data, you need a patient identifier, you need age, laterality, you need gender, you need diagnosis, and use international accepted standardized codes. Implant details, barcode information on the box, hospital type and volume, and eventually surgeon and volume. I don't think the last is really necessary. Level 2 data implies more information about the patient, and the list of potential data elements is endless. BMI, comorbidities is what is done in several registries. Recently, the Swedish started collecting that as well. But you can really collect endless comorbidities as such. You can also look into the process of care, the operating theater environment, the surgical technique, AB prophylaxis, thromboembolic prophylaxis. Part of that is collected in the Danish registry. Then go to level 3 data. Outcome tools. Ask the patient, how are you doing? With different standardized score systems. Patient satisfaction. And depending on the tool, this could be a surgeon or a patient responsibility. Of course, move it towards the latter and ask the patient, how are they doing? And level 4, we have the fortune, or disfortune, that we can actually look at the x-ray post-operatively and that follow-up and predict and go back in that way and more in detail analyze what is the surgeon's role in the failure of what we are looking at. I don't think we need any more new implants. We need better education of our surgeons. The International Society for Arthroplasty Registries, with that web address, aims to support, to be a support network for established developing registries, encourage cooperation and sharing of information, encourage collaborative activities, and the current president is Ove Furnes from Norway. I think he's somewhere around here. But go to the website, there's much more detailed information. NARA was recently established as a cooperation between the Nordic countries. Finland is included now. I haven't seen data from Finland, but I guess that will soon come. A very important initiative to really work internationally across borders. I will go back to the Swedish registry with this web portal, where the mission is to improve the outcome, and it's a quality control system. It's not an implant registry. Note that a registry identifies problems, but no solutions. We still need dedicated research projects with traditional scientific design. Look for US. Majority of the surgical, or majority of the total hips in US is done by low-volume surgeons, meaning they're doing less than 15 a year. They're not fellowship trained. All publications are coming from institutions like the one I'm representing, where we have surgeons doing 600, 700. And of course, the outcome that we can present from Mass General is not what the general outcome is in US. We know that the registry has improved the quality. Here an example from Sweden that in 10 years, all units moved up 3% in outcome. A tremendous saving for the society, a tremendous benefit for the patients. And of course, this is what the registry is doing. Let's look at different registries. England, Wales, Australia, Canada, New Zealand. I'm trying to quote how many papers. If I go to these websites, I can see there's 7 peer-reviewed papers from that specific registry. Norway have a wealth of information. I'm coming back later to that. At least 50 total hip papers in peer-reviewed English literature. The Danish, approximately 15, started later, peer-reviewed papers. And finally, the Swedish, that for some reason the website stops at 2006. I don't know why, but there's at least 60 there. So you can look at the basic registry information when these registries have started, the percent coverage. Canada is still not good enough. They need to get higher in order to get into the real society. Total number so far presented, and the annual number in the latest presentation. So UK, or England, Wales, as it should be named, 71,000 total hip procedures in the latest report. They are collecting very fast, very important data. Basic demographics. Mean age is more or less the same wherever you look. Sure, we are doing more younger, but we are doing more elderly patients as well. And outside of New Zealand, they're doing few female. I don't know what and how that comes. Otherwise, it's relative constant. Canada is not doing too many females either. Indication for doing this is relative uniform as well, outside of fracture. It seems like Denmark, Norway, Sweden, Scandinavia are doing more and more primary total hip for fracture, unless there is a classification issue. A very interesting observation that I hope we can get feedback. Is it worthwhile doing this? Rheumatoid in general is getting less and less frequent as indication for doing this. Sorry. So there's really no major differences in basic demographic. The quality of the information could be improved by a consistent use of ICD-10 across the board. Type of fixation, then there's really no agreement anymore. Canada, 3% cemented, up to Sweden, 85, I think it is a misquote, 87. There's no consensus how to do this. Resurfacing, 10% in Australia, down to hardly used in the Scandinavian registry. And of course, that will give us a lot of very valid information at the same time. So, mode of fixation. Reason for revision. I can't prove it, and I haven't done enough statistical analysis, but it seems like those that go uncemented and abandon cement, they get more osteolysis problem. Could be right. And wear problems. Poly might act different in a metal backing versus a cemented environment. Outcome, revision burden. This is a paper from Steve Kurtz, 2005. And revision burden, a very crude measure of the temperature in a community, where you take revision and divide by the sum of primary as revision and get that percentage. But you can see there's some really high up here, US 17.5, and only on Medicare population. I'm coming back to this later on. Outcome from Australia, I showed some of these slides yesterday. The purple curve, cement, is, no, the blue curve, they're doing like the Swedish knee registry. They're turning these curves up and down, and that's confusing. But uncemented is doing worse, justified for gender and for age. And it doesn't matter really if you go to the real young group. It's not that there's any specific group in the Australian registry benefiting significant for uncemented technology as it looked, at least when they started 8 years ago. Exactly the same with the Norwegian result. I showed you that yesterday too. And what they did, they retrained the surgeons using the traditional old Charnley total hip arthroplasty in Norway, and all of a sudden could improve that up to unbelievably good figure, just by focusing on training the surgeons. The implant is unchanged since 30 years. So put it in correctly, then you get a good outcome. Extremely interesting. And sure, they still conclude, Ove and Leif from the Norwegian Registry, you can use cement in any patient, any age, and any diagnosis. You have as good an outcome. So think about that. Go home, do it. England, Wales, a decrease in use of cement, despite the fact that implant survival, only 3 years out, implant survival is in favor of all cemented implants. So it is kind of a paradox why this happens. Sweden switched to the inverse hybrid, quite significant, the blue curve versus the red. So all of a sudden they cement the cups and run uncemented stems. And where is the outcome of the inverse hybrid? It's the green curve here, as opposed to the all cemented. I wonder why. And you see in Sweden, as I showed you yesterday as well, increased use of these, I would say, in the registry result, unfavorable fixation principles. So why is England, Australia, Norway, and Sweden shifting from all cemented to uncemented when the survival with proper statistical analysis shows superior results for all cemented? Level 2 data, I will give you this slide of peer-reviewed papers from the Norwegian Registry, probably the best way to use result. They have been definitely the best registry in the world to use result and combine their level 2 data and do papers on health economy, hospital volume, patient satisfaction, mortality, primary revision, and outcome revision total hip. So just go to their web page and you will learn a lot. Level 3 data then, where the patient reports how they're doing, Sweden again. There's a lot of unrecorded failures, and there's a lot of unknown if the patient have continuous pain or are really unhappy with the outcome of the procedure. And what is the utility for the patient? It's PROM, patient-reported outcome measurements, where you use generic instruments, and EQ5D is the one to use, and you can use disease-specific instruments if you want to do that as well. So what Göran started, Garelic started in Sweden is the PROM database, where you use your EQ5D, 5 questions, relatively simple. You justify by a case mix indicator, and you ask about pain, satisfaction, and you do that on predefined follow-up times. This is more information about the EQ5D. You can go on the net and you can get information. It's translated to 62 some different languages. And then you can look into quality-adjusted life years, a utility measure that combines health-related quality of life and survival. And you can now go back to the clinical value compass and basically fill in all dimensions in this. Still, by running a national registry, by combining that to other existing registries in society. And how can you use it? You can do a balanced scorecard like this and look in patient satisfaction, pain relief, gain in EQ5D in quality of life, mortality, cost, reoperation, implant survival, 5 and 10 years. And you can map a clinic. So the chief and the surgeons at the clinic will know we are not doing as good as we should. We need to improve. And this is public information in Sweden. Every clinic is scored like that. Any patient can go in and see these guys are not good in this and this aspect. And of course we are competitive. Of course we will improve and learn from our mistakes. This is the ultimate way to use registry information. Let's go to level 4 data then. One of Gorelic's old pictures, these are two of the most, in the past, used cemented implant in Sweden. And this patient, that everybody here can see is a clear failure with osteolysis, but not revised, therefore not recorded as a failure, as this one is not recorded as a failure. So we started up 7, 8 years ago at MGH, a registry that capture clinical and radiographic data from any patient coming operated in the system. And we analyzed cup position and got the Shanley Award for that at the recent meeting, and this paper is accepted, and I have it in Blueprint. You can find it in Core in December this year. So we looked if there's a correlation between patient and surgical factors and the positioning of the acetabular cup. We had 1825, where we had x-rays available in the registry. We looked at all primary revision and resurfacing, and we looked into age, gender, laterality of the operated hip, BMI, and pre-op diagnose. We looked at the surgeon doing few or many cases, the approach, and what head size he used. We used the Mattel software to determine the inclination of the cup, and you can get the version of the cup as well, and then we used MDisc in order to see if it was retroverted or anteverted. I have this one patient, a metal patient, and it's green on this slide here. This is where the cup should be. This is where we actually found the cups at the analysis. So we had 37% where they should be, meaning the remaining is outside that. And those steep here, if that was metal we have used, there would be high risk for problems. The best surgeon had 45%. The worst surgeon had 13%. These are fellowship, dedicated arthroplasty surgeons. The best approach was the posterolateral, with 43% in target. The worst was MIS, with only 18%. So clearly, if you don't see what you do, you don't get a good outcome. Don't do MIS. And then you can do odds ratio for significant indicators. I will brush through that fast because it doesn't really matter. It just confirms what I showed. What happened to the patient? She was 4-year post-op, had pain and squeaking, more than 100 parts per billion chromium and cobalt level, and had a severe osteolysis behind her cup. So how good are you? You're thinking, we're better. We are much better than these guys. Absolutely. So we just finished. We took a community hospital, non-identified, will not be identified, and we measured their 1,800 cases, of which 500 were metal and metal large head. And this is the result. So that's not the implant's fault. It's the surgeon's fault. So can we improve precision? We need to be aware of what we are doing. That's one of the basic parameters running a registry. Feedback will improve. We can maybe improve instrumentation. We can definitely avoid mini incisions. We can do navigation if we can afford it. We could be cautious with hard and hard bearings, especially metal. And of course, we did a follow-up now. Have the surgeons improved? Everybody has improved 10 or more % in their cup position, just by giving them the facts. And I'm sure we can be even better than this. So do we need a registry in US? Revision burden Medicare patients, Sweden 6.4, US 17%. The outcome shown several times here, the outcome in US is not nearly as good as Norway and Sweden. Drop that. We could save a lot of money in US doing this. For each % lower from the 17.6% revision burden, we could save annually $100 million. A 10% reduction to the Swedish level would save $1 billion per year just for hips. So we do need a US registry. Will it ever happen? It would, or it will. It had happened. We have started July 1st. With this governance structure, 7 surgeons, 6 non-surgeons, industry, payers, hospital, and a lay or public member as well. We will only start up collecting the most simple level 1 data, nothing else, because if you make it too complicated, you will never ever succeed and get a result. So in summary, registries can provide critical information on demographics, identify clinical problems, but not solutions, will be very useful for future resource planning and allocation, and seems, in Scandinavia, to initiate a sound conservative attitude. It will be extremely useful in future cost, utility, effectiveness estimates, and it seems to be needed even in US. For the healthcare providers, the potential is large savings. We just need to convince them in US. For the patient, this is really a win situation. And for the professional community, listening to this meeting, there's an enormous research potential. Thank you.